Laura, you got a quick link to the crew report and see. I can find.
We're good? You know, I noticed earlier, Chairman Larson had this thing completely disassembled.
This is a hand guard. This is finger guards,
Oh.
right?
I have a brother just like you. We couldn't buy him Christmas gifts because he took them apart. Let me move that. Welcome back to the afternoon session. I'll be chairing this afternoon. We've got a couple things on the agenda this afternoon. The big thing I think is going to take most of the time is the K-12 mental health services, but we're not going to start there. We're going to start with adolescents with high behavioral needs and work through some things there. Do we have Lindsay online? No?
Lindsay's right here.
Lindsay, it's amazing what I can see when I look right in front of me. Lindsay, would you like to lead us off on adolescents with high behavioral needs? Thank you for coming, by the way.
Thank you, Chairman, members of the task force. So I just wanted to provide a quick update on the request for information. Just to level set, this has been a collaborative effort between the Department of Family Services, Department of Health, and Department of Education, really just asking for our community partners, providers, stakeholders to give us some ideas on ways that we can solve the identified challenges that we've outlined here. Since the last meeting, I've entertained a number of different conversations. WISA submitted feedback on the RFI in writing. We've worked to incorporate those changes into the document. I had two separate meetings, one with some community providers here in Cheyenne, another conversation with a community provider up in Gillette. So I hope that the updated and revised document appropriately reflects the feedback, the changes that we made, and really the number one ask of the providers was to open it up and make it a bit more flexible to allow some innovative thinking and problem solving outside of existing statute rules and regulations. So that's what we've done. So the updated document has been provided. We put a 60 days for responses. Those will be due just by email Monday, October 9th to Manhattan, who is our DFS clinical services manager. And I think we're all excited to see what comes forward and to hear from our providers and our partners on how we can go about addressing the need.
Committee, questions for Lindsay? You've got the document in front of there with the RFI on it. Any questions for Lindsay? Any answers? Go ahead, Mr. Chairman.
And I apologize, Lindsay, if I wasn't paying attention well enough, but has that gone out?
Chairman, co-chairman, yes.
Okay, thank you.
I believe you said 60 days, correct? 60-day period.
Chairman, yes. So the revised document that we just released, the LSO is posted, has the deadline 60 days out for proposals.
Great. Committee, further questions for Lindsay? Seeing none. Thank you very much. Seems that Director Johansson is on his feet already. Let's put him on the spot. Director Johansson.
Mr. Chairman, I'm sorry, I might have missed a question for me.
Oh, you're up. You're next on the agenda here talking about Plan B, sir.
Okay. Mr. Chairman, members of the task force, at our last meeting, we talked about, in context of this RFI, and not knowing what kind of responses or the extent to which we will get responses to the RFI, of what the Plan B would be. And those of you who were inland or toured some of our buildings on the Life Resource Center campus that evening after the first day of the task force to see if we could, how would we scale a pilot project for this high need adolescent population at the Life Resource Center? What would it look like? Which facilities or buildings would we use? And so hopefully the information I'll share with you today kind of summarizes or at least puts into context some of the things you saw on site. And so the Plan B wouldn't solve the entire problem, and I'll tell you why. As you know, we have 10 to 20 of these adolescents at any given time that we're struggling to find placement for. And the real temporary need is for a temporary residential space while the Department of Family Services, Department of Health, and Department of Education continue to look for appropriate services and placement for some of these extremely high-need children. And to put it very bluntly, what we're looking for in many of these cases is something that's marginally better than a detention center or an emergency room. Hence, depending on what we get back in the RFI and what that looks like and the policy decisions of the legislature going forward, if we were to try to scale a unit similar to what we're discussing at the Life Resource Center, we would propose a 5-bed facility, basically a surge unit, where we could temporarily house and treat and provide services with our partner agencies as well for those children. We've costed that out based on some recent experience over the past 2 or 3 years, where these high needs adolescent cases have in small quantity come to the Life Resource Center, and we've provided services to them. On the capital side, as I mentioned, we currently have and would propose 2 empty cottages that are unlicensed, that would be repurposed and be able to house both genders of adolescents. On the staffing side, in terms of direct care, based on the significant behaviors that we see in this population, our sort of baseline assumption is 1-to-1 staffing on average, or at least 1-to-1 staffing on average. What we've seen is that over the course of the first few weeks, we're often able to move some of these cases off of 1-to-1 staffing at the facility, but we assume that initially because we also know that some of the clients that we've had at the Life Resource Center are 2-to-1, in rare cases 3-to-1 staffing. So based on that 1-to-1 staffing model and 5 beds, we would estimate 4 to 6 full-time equivalent staff per resident, which means for that unit, we would be requiring 30 total staff for 24/7 care if the census of 5 was full. And you can break that down if the census was 1 or if the census was 3. So we would likely need new staff at the Life Resource Center, approximately 20, as I mentioned, 20 to 30, depending on the actual acuity and the daytime support that was needed. And when I say daytime support, we've had cases where, again, in conjunction with partners, some of the special education and daytime services, for lack of a better term, is provided, and that reduces the Life Resource Center staffing demand for that population. And then we would provide educational staffing, special education via contract tutors or placement and partnership with local districts. And like I mentioned, residential staffing on our end would decrease if full 24/7 custodial care is not required, basically in that 8 a.m. to 3 p.m. window. In terms of the budget, we costed this out as well. There's kind of 3 items. We have fixed cost of administration and support teams. So think of medical services, nursing, therapies, and that would all assist in the all-inclusive care, but represents a pretty significant fixed cost. In the cases that we've had to date that kind of fit into this high-need adolescent population, we've done that with the staff we have. And here's the benefit and the bug. Right now, as you know, we are low census at the Life Resource Center, primarily because we can't find, recruit, and sometimes retain staff. So it's endemic to the health and human services industry right now. We're certainly no exception to that. But in the emergency cases that I've placed at the Life Resource Center, we have surged staff that we currently have to serve that population. So while that's possible to do, if this were directed to be part of the Life Resource Center's mission, then it wouldn't be a long-term solution, in my opinion, to surge staff for the high-need adolescent population, because we're just taking it from other units. So if you assume full census at the Life Resource Center now, with our adult population, our current mission, then again, it wouldn't be a long-term solution, although something we can do in a pinch or in an emergency. The other part of our budget assumptions are educational cost, again, generally paid for by the home district, but folks involved in these cases know that gets complicated. Dr. Ballard is well aware of some of those issues that we struggle with who pays for what when it comes to educational services, but something that we have assumed in this modeling that would be district funded. And then our variable cost, that's where it gets more interesting. So we've broken that down into salary and benefits, food, utilities, and emergency clothing, which sounds like something that we wouldn't need to cost out, but you'd be surprised in the kind of clothing and other types of sort of what you consider essential goods need to be procured. That total on a monthly basis per member, we estimate at $16,258. So, kind of all in for a year cost of 5 would be about $1 million when we use the Life Resource Center structure and budget to cost that out. Again, these are estimates. I want to be very clear on that. And sometimes you have to dip your toe into the pool before you understand the water temperature. So there's still some unanswered questions with this, but at least it gives the task force something to react to when it comes to the what we think on the state side it would cost to provide. And given that we're leveraging, again, current state infrastructure and fixed costs that we currently have at our facility, in this case, the Life Resource Center, I don't know how that will compare to what, if anything, we receive back in responses on the RFI from the private sector and nonprofit community. But it's worth noting that we do this in our other facilities too. For example, at the state hospital, we have a waiting list. So when folks are on Title 25, we pay out of that budget for folks on the waiting list to be housed and treated at hospitals, designated hospitals like WBI, Cheyenne Regional, or general hospitals. And so there is a interesting kind of willingness to pay or cost matrix that you have to consider when you're going to potentially leverage a state institution versus contracting it out. And it can often appear, cheaper, more cost effective to do it with the state infrastructure, but there's pros and cons to that. Again, we have the space. We have some buildings that are part of the old campus at the Life Resource Center that are hardened, that have the kind of security that we think in some of these cases we would need. And outside in the communities, if we were to invest in that, sometimes those upgrades would need to be paid for, which we asked about in the RFI. What kind of physical plant demands would be there, remodels, conversions, things of that nature. But as I talked about in the previous meeting, my perspective on this is the problem's not going away regardless of the policy considerations or decisions of this task force or the legislature. We still have this population that I think Director Schmidt and I, and certainly Department of Education, agree we can do better with. How you accomplish that, again, my perspective and recommendation is a diverse investment approach. So we think with our current staffing levels, the reason we're proposing no more than 5 beds is because right now, if you asked, we cannot do this. We do not have the staff to be able to implement this unit right now. Now that situation is getting better. We're optimistic with the compensation adjustments that happened. Some of the efforts that we're undertaking to recruit, to be flexible, to attract the kind of labor and specialty labor that we need at these facilities. So I do think our problem with staffing is going to improve over time in the short term. But again, that's the reason you'll hear a kind of a lower bed proposal here if we need to pursue this quote unquote plan B. But I also think it's a benefit to look at a diverse approach, because while we might be able to stand up over the next year or two, 5 beds at the Life Resource Center, it just stands to reason for me that if we had 3 beds in Gillette or 5 beds in Casper, that diverse approach, both geographically and by provider type, I think could be an interesting way to move forward. With that, Mr. Chairman, I know that was a lot of information. I do have this written down if anybody would like to see it, but happy to stand for any questions.
Questions? Go ahead, Chairman.
Thanks. Just checking, does that include any of the educational costs? That's just kind of care without the educational component needing to come in as well.
Mr. Chairman, Chairman Zwanitzer, that's correct. So we assumed in this model that the educational costs are paid for somehow. And typically, again, I think that on the special education side, it's generally through the district, the home district of the student.
Could I have one more, Mr. Chairman?
Follow up, go ahead.
And not to get exactly into financial numbers, but when we have to transport a child and place them in one of, I think, 6 or 8 facilities around the country, that 16,000 number, is that comparable to what we're paying to place an out-of-state kid? Is it, I mean, much cheaper, much more expensive, without getting into specific numbers when we're talking about an RFP?
Mr. Chairman, Representative Swanitzer, it's a good question. The frustrating answer is it really depends on the case. So we do have out-of-state facilities enrolled in Medicaid, PRTFs, for example, that accept the rate. This would be higher than that. But in these extreme cases, we've seen, and I'll look to some folks that we've worked on a lot of these cases with, we've seen higher than $1,000 a day. We have a facility that I won't mention by name that just notified where we have a client, an adolescent placed there. I think the monthly cost, the monthly rent for services all in went from $30,000 a month to $50,000 a month just in the last couple of weeks. So that there are cases where absolutely this is better than break even when comparing, but it really does depend on the case.
Can I ask one more, Mr. Chairman, then? And it revolves around state funds versus federal funds, Medicaid. Do we have any, is there a percentage on average we think that half of the kids now are on Medicaid who are being placed, or higher or lower? What would the state cost be versus what we can?
Yeah, Mr. Chairman, Representative Swanitzer, another great question. We assumed in this, because we would be looking to leverage the Life Resource Center campus, that there would be no federal funds in this cost breakdown, and there's a reason for that. We have 2 licenses at the Life Resource Center, the Intermediate Care Facility, or ICF, and the Skilled Nursing Facility. And those obviously have a significant amount of federal funds that come into that, unless this temporary, holding facility that we're talking about here would be essentially meet the level of care or licensure for a PRTF, or a psychiatric residential treatment facility, then Medicaid funds would not be able to be matched into here. And so that, again, it's an interesting policy point of, do we want a state-run and state-owned psychiatric residential treatment facility? Our assumption was no. This would be solving a problem of looking on a temporary, 3 to 6 month timeline. Can we provide services and hold a client while the agencies work to find the more appropriate setting with the right specialty care, whether in-state or out-of-state? So we assumed that $16,000 per member per month that I mentioned would be all general funds for 5 residents.
Chairman Larson.
So Director Johansson, going back and reiterating some of the assumptions that we've had thus far in this conversation, this is short-term to keep these kids safe on their medication and receiving their education while we find a more appropriate long-term space. Help us understand a little bit more, if you would, because it's not so much on Plan B at the Life Resource Center on the asset part of it. The assets are available, but you talk about this IMD, institutional mental disease, and how that impacts. And so if you would just take a minute and help us understand who can be reimbursed for Medicaid and in this mental illness, and how this little component, and why you're only doing 5 is, and how that ties into the folks coming from the state hospital, and just to kind of paint a clear picture that it seems logical until the regulations get involved.
Mr. Chairman, Co-Chairman Larson, you're right. And the reason, to reiterate one point and expand on another, the reason for the 5-bed target here is partly because of the staffing issue I mentioned. And secondly, what we discovered over the course of remissioning the Life Resource Center and rebuilding it was that we have to be very careful to not get a federal designation called an Institute for Mental Disease, or IMD. The reason for that is that there are no Medicaid funds that are allowed for adults, so 18 to 64. you cannot have federal reimbursement from CMS in an institute for mental disease. For example, the state hospital is one of those. We have some Medicare funds for our long-term or geriatric patients there, but no Medicaid, even if folks are Medicaid eligible, because it's considered an IMD. So we planned through the facilities task force very carefully of what the population mix would look like at the Life Resource Center when it comes to their primary diagnosis. And if you serve in a facility, if 51% or greater of your population, if their primary diagnosis and needs are mental illness or mental health related, then you will be designated as an IMD or an Institute for Mental Disease, therefore prohibiting the Medicaid funding for your adult population. So the logical question is, well, why does that matter if we're talking about kids? It matters because of the population that's served, the adult population at the Life Resource Center, that we can't tip that balance because we risk the federal funding for the entire facility without a waiver, which gets complicated. There are some mechanisms there, but they're not easy, and I don't know if our facilities would be able to achieve the things that are necessary to waive out of that IMD exclusion. Right now, the good news is that we don't think with a unit like this we would risk the IMD designation, because so few of our patients at the Life Resource Center right now are primarily diagnosed with mental illness. But that will grow over time as we staff up the Life Resource Center, populations from the state hospital moving to Lander. Our percentage of those with mental illness served at the Life Resource Center will grow. So we just want to be careful about that. And if we assume full census and full capacity at the Life Resource Center, hopefully in the short term, but in the future, we just need to be very careful with that balance. And so the entire population, as Director Schmidt and I have discussed, of 15 to 20 bed facility at the campus of the Life Resource Center may not be the best course for the state, given the risk of federal funds we would have at that campus.
Follow up, Chairman Larson.
So Director Johansson, looking at if one of the vendors or providers responded to the RFI or multiple vendors, and we was able to do that out in the state, is there anything statutorily that we need to do to allow this to be put into place, is the first question. And then if I could just follow up with the second one, is I will make the assumption that if we didn't have any responses to the RFI and we come back and looked at Plan B, that you could initially do this at the Life Resource Center without a statutory change, but if it became permanent, then we would probably have to change statutory on the mission of the Life Resource Center. So if you could just...
Mr. Chairman, the same answer to both of your questions. I agree. I don't think in the short term statute change would be needed for either respondents to the RFI or a pilot project at the Life Resource Center. However, if this is a level of care that we make permanent in either context, I would strongly recommend statute change. Right now, as Director Schmidt knows, we have the authority, we have the ability through the Interagency Children's Collaborative, which we would propose all of these cases go through that mechanism so that we have a review and a filter to look at who's most appropriate for placement. Again, whether it's in a partner facility through the RFI or at the Life Resource Center, so that we adjudicate them that way. If something like this were to be made permanent, I agree 100%. I would request that it be added to the mission of the Life Resource Center in statute, given the work that was done going on 10 years ago now with the Facilities Task Force, to really do the good work of saying, what's the mission of the state hospital, who's served there, who isn't, and same for the Life Resource Center. If this becomes something to make permanent, we should codify that in statute.
Another follow-up, Chairman Larson.
Follow-up, and this question is more to Chairman Nethercott, is it would seem to me, because the agency has already submitted their budget to the governor on this, and we're going to have to, if we held off, if we don't get this somehow done during the budget session, then we postpone that at least another year before we do anything. So I think the question is that, would you agree that we kind of need to be ready to look at the recommendation we come back depending on the RFI, or at a minimum, separate from their budget, to do a pilot project and be ready for that conversation? Does that make sense to you?
It does.
Okay.
And Mr. Chairman,
Go ahead, Director.
I'll apologize in advance to Chairman Nethercott. She's going to have a coronary when she sees our budget request later this winter. But to that point, again, in the short term, if we were going to stand up one of these beds or all 5 of these beds, given our staffing levels, I want to be transparent. I think we could do it, but it will detract from the mission of the Life Resource Center now. So it's really is a choose your own adventure of, if we did this right now, then we would delay admissions for some of the state hospital clientele or the high needs clientele on the adult side that are slated for admission at the Life Resource Center. So I don't want to get overly aggressive saying if this Plan B is operationalized, we need to put this in the budget and this many FTE, because we could probably work with this task force in the legislature to see what we could do in the short term. But again, if the expectation were to do it separately, then I think we would want to have that discussion separately.
And maybe just conversation, but we continue to trip over ourselves when we do that, because we rob Peter to pay Paul. And so we're talking about trying to get these people moved out of the state hospital and into Lander. But then if we're able to staff, we postpone that staffing, then we back up the state hospital and we're putting them at designated hospitals. And so the logic behind that, I know there's a way, but I think it defeats the intent of what we've been trying to do.
Mr. Chairman, I agree 100%. Just making it known that in an emergency, it is an option. But you're absolutely right.
And it's known. Further questions, committee? Go ahead, Chairman Swanson.
So we discussed last meeting that some of these proposals could be small scale, 5, 8 kids. So the question is, we could still, if we got a successful proposal that said, in this corner of the state, we can handle 5, but there's still a need, we could simultaneously do something internal and accept an RFP, correct?
I believe that's correct. Further questions, committee? Senator Nethercott.
Mr. Chairman, thank you.
You got over your corner. Okay.
Just wonder what the Department of Health is going to do for my coronary. So I've been primed about your budget already. Don't worry, Director. So side note, it's regionally, I'm assuming that there's a shortage of these type of facilities for these type of youth, not just in Wyoming. Is that an accurate statement?
Director.
Mr. Chairman, Senator Nethercott, yes and no. Yes, in the sense that we're having trouble accessing them. Maybe, I think there's facilities there. It's just we're seeing a major limitation in being able to place kids based on either cost or other exclusionary factors, liability issues, gender issues, conditions that facility X does not accept. So yes, I think the shortage, it has some nuance to it, but absolutely for this population, we struggle to find placement. I'll add, though, that this type of facility, what's being contemplated here, it certainly doesn't exist in this state. I mean, the mission is very custom to say this is a holding, a transitional or temporary location while more appropriate placement is being sought. And so when we, at least in the Department of Health world, we think of different levels of care. okay, this is inpatient hospital, this is psychiatric residential treatment, this is residential treatment center, this is group home, et cetera. We're not really talking about anything specific in terms of that licensure or designation, really kind of a custom plan for this really small but challenging population.
Mr. Chairman, let me just throw out this idea, which may be reckless and irresponsible. Knowing that Wyoming will never have an economy of scale for providing any of these services to these at-risk youth, and not necessarily for this particular type of unit, recognizing its very narrowly tailored purpose, but a broader picture, in order to eliminate even the need for that, is to potentially create the larger facility where they would ultimately go, attracting regional at-risk youth as well. So not just trying to serve Wyoming, but having a broader focus and potentially supplant a good deal of the costs externally, recognizing that we would be serving a population not just within our state, but outside. And that would be thinking outside the box. And I don't know if it's viable or not knowing enough about how all that funding works. I have no idea. But is that something to consider, that as we would Wyoming could take a risk of an investment, recognizing that we would be planning on a portion of that investment being paid off through external, other states shipping their at-risk youth to us?
Director.
Mr. Chairman, Senator Nethercott, it's a really good point. I don't think it's reckless at all. I just, as somewhat of an amateur economist, it's perplexing that we know there's demand for something, whether it's to your point, an all-inclusive facility that can do a lot, or, a temporary place like we're talking about here, but that supply is not connecting to the demand. And I think, to your point about the scale, that's likely the reason why, that you don't see as much private investment in Wyoming for a place like this, because the volume would be low. Even if you said, well, let's be a regional center where Montana and Colorado and Nebraska and Idaho send their children as well, it's certainly possible. And I think it should be explored. And I would just conclude and say, I think this first stab at the RFI, I think, goes in that direction, to look at, and again, that's why it's kind of a blank check approach and a blank canvas approach to say, what would it take, even if it's 5 beds or 20, what would it take in capital investment, and maybe get a sense of what that looks like over the next couple of months.
Chairman Larson.
So Director Johansson, I just again would, as we contemplate a state investment in this, now, is it fair to say that investment or that cost is currently in place? The cost is in place, it's just being borne by either hospitals or counties, or who do not have this as part of their mission to handle kids of this nature and of this age?
Director.
Mr. Chairman, Co-Chairman Larson, that's correct. So, to Senator Nethercott's point, I do think there's efficiencies, if not cost offsets or savings, that can be achieved here. Who they accrue to is the difference, where I don't think it would be to the Department of Health, Family Services, or Education necessarily, but yes, there's infrastructure and services and costs that are being incurred by local communities, detention centers, emergency rooms, et cetera, that this would, in theory, offset. What that balance is, how much you invest in it versus that offset is hard to say.
Further questions for the director? Answers for the director? Okay, thank you, Director. Okay, any public comment on this topic before we move on? Welcome, Task Force. Go ahead and introduce yourself.
Mr. Chairman, my name is Bruce Berkland. I'm the Executive Director for the Wyoming Youth Service Association. And our members certainly know the need for this type of facility and support that. We would just add that as this process moves and moves forward, that you keep in mind the programs that are upstream, that such as our PRTFs, RTCs, group homes, who have served a number of these youth and continue to serve high needs youth who are at risk becoming difficult to place youth. And if we have the staffing we need to serve those youth, the number of hard to place youth can stay flat and hopefully decrease. And if our programs aren't able to serve those difficult youth, then they'll become more hard to place youth. So we would urge that as you think of that overall process, that those people upstream, those programs upstream are also an important piece of keeping this workable. And so as Director Johansson has said, in terms of how many of keeping those numbers down so the facilities that are available can serve and meet the need. We are engaged in a process with the Department of Family Services on assessing actual costs for our programs so we can have clearer data and provide more clarification to what that need is in the coming months.
As a segue, being a person with your boots on the ground, look into your globe, look into your magic globe there, and I want you to tell me, based on the last 4 years with the population growth, which is minimal in Wyoming, looking the next 5 or 10 years down the road, do you see this number in this category increasing, decreasing, staying the same? And this is just speculation on your part, but what do you believe is going to happen?
Mr. Chairman, I would say that it goes back to what I was saying. If the programs upstream can't maintain what they're doing now or improve, that number will increase. Okay. If those programs can continue and improve their service, in particular by having the hiring and maintaining the staff we need, then I think those numbers can stay flat. I would hope they would decrease. I think I submitted via Representative Larson some ideas from the Wyoming Youth Service Association that would help in terms of possibly decreasing that number for the facility and better serve those youth in our facilities and maintain them in our facilities. They're there now, but many of those hard to place youth have left our programs and had to move elsewhere.
Very good. Questions for Bruce, committee? See none. Thank you, sir. Further public comment? Pretty wild group we have here today.
It is.
Yeah. And I didn't give any of them Valium.
I have Rice Krispie treats.
Rice Krispie treats, it's kind of like Valium. Okay, no further public comment. Committee, any further comments before we move on? Discussion, ideas. Obviously a need we have, and I would like to think that this need will go away someday. It won't. It's always going to be there. What needs to change is the way we deal with it. It's something we can do better. So we need to deal with it better. So very good. Okay, committee, we're going to move on to the next topic. We excuse speaker as he had to leave for a family event, and which is because I told him he was going to lead part of this discussion, I believe. We're going to move on to K-12, mental health services. We had a subcommittee meeting recently. It was a fairly long subcommittee meeting, and I will, in honest disclosure, I will tell you I was on the internet and I faded in and out. It was like a bad seance. I was here, I was there. Yeah, I missed much of it, but what I did catch was very good. And so aside from what our agenda says there, we're going to do it just a little bit different. Dustin Brown did a presentation for us, and I think it was very enlightening. I think it gave us some good information, and I think it was beneficial for us, and it will be beneficial to this entire task force. And so we've asked Dustin to come and do that presentation for us. And I think it's a very valuable, and I think it will help this discussion and help the committee a lot as we move forward. So Mr. Brown, the floor is yours. Introduce yourself, sir.
My name's Dustin Brown. I'm a member of the Wyoming Department of Education. I'm the Wyoming Project Aware Director serving under Laurel Ballard. What I've been doing since...
Mr. Chairman.
Oh, sorry.
You got it? Is your microphone on?
Oh, no problem. Since 2020, the spring of 2020, we've been working at what successful mental health integration looks like within the K-12 setting. We've done that through a series of federal grants. Those grants are under the SAMHSA grants under Project Aware. And what these do is they give you the opportunity to create infrastructure development, support students in the K-12 setting through direct counseling services. And is there a way for me to share the slides by chance? My apologies.
Mr. Chairman, you did sign up for the Zoom. So if you
Yes.
want to join the Zoom, then you can share slides.
Yeah, if you wouldn't mind, ma'am. So the work we started with, in addition to the Aware federal grants, we've also been able to utilize a CDC grant to duplicate our efforts, in which we've created a hub and spoke model. And then we've also utilized some additional funding to create that model, extend that hub and spoke model, as well as create two more additional districts. Now, in total, we are operating in 13 total districts. We utilize 9 community project managers to manage those districts and the K-12 mental health efforts that we have in here. Next slide, please. So what I'm going to share with you today is overview of Project Aware, kind of as we've been talking just now, but also some data, survey results, developmental data that we're currently working with, and then lastly, our theory of change that we're utilizing through Project Aware. And I would encourage you, by all means, please interject as we go through. It's very not routine kind of general ideas that we're walking through here, so please, by all means, interject as you have questions. Next slide, please. So this is some data that has been presented before. This is the state of mental health in America. This is a survey done in 2022. When we look at Wyoming, we have 17.59% of students are experienced with major depressive episodes. That's a little bit slightly higher than the average we see within the country as a whole. So, again, we have the number 1 per capita suicide rate within the United States. That's something that has become very prevalent knowledge within the communities that are working in this sphere. Also, that Wyoming has the highest prevalence rate of youth-based major depressive episode in the US. This is all data that comes from that report taken again in 2022. Next slide, please. Oh.
Go ahead, sir.
Dustin, I just had a question on that 4th bullet there, and we've had this conversation earlier today, but you note the lack of access to service. Are you identifying that as we just don't make it available to the students, or that the professions do not exist in the quantity to provide the services, or is it a combination of both?
Mr. Chairman, co-chair, it's really a combination of both. We have a strong number of physicians within the workforce. When you look at us comparatively within the US, a lot of the problem is geographic distribution of those individuals. In some of our smaller communities, we may have one individual to take care of a population. When you look at our modeling, we've modeled 4% of our population needing those one-on-one services at any given time. When a counselor can have 35 to 40 individuals on their caseload, we're talking about months down the road before you can get traditional access in a lot of our communities. So it's truly a combination of both. And especially when you start looking at more advanced cases and the appropriate skill sets to take care of those cases.
Okay, proceed.
Yeah, next slide, please. So this is what Wyoming Project Aware looks like. This is all of our school-based mental health services that we offer. Right now, again, because we're on federally funded programs, these programs start to twilight in 2025. Our first program will twilight. We actually did have a CDC project that twilighted, but it's moved over to the Mental Health and Substance Abuse Treatment Grant. So a lot of this is trying to find the right way to keep this work going. Lastly, we just implemented Care Solace, which we'll talk about later. This is a care coordination service within the state. And what these do is they do the handshake between the school district and the family and the behavioral health organization that's going to provide those services to our students. So, for me, if I have, yes, sir.
Is that something that would be, it's kind of a wraparound
Correct.
services? Does that not already exist with our Magellan contract? Should we, I guess what I'm saying, should we already have those services available?
Ms. Ballard, go ahead.
Mr. Chairman.
Director.
Thank you. Very quickly, Dr. Ballard. Yes, we do operate the care management entity, which is a children's mental health waiver. It varies by region of what services and provider network is available. And obviously you have those Medicaid eligibility standards in place for that population.
And so I guess would it be similar, or the care coordination be similar, or is it just a different beast altogether?
Yeah, Mr. Chairman, Mr. Co-Chair, this service would be duplicated. You would also see it in private insurance health plans. So it's the care coordination in and of itself is not a unique service, but the way we're presenting it with this, it's a unique way to present it from targeting the student population of Wyoming, where we're essentially paying for the entire student population of Wyoming. And we're receiving services for all family members, all WDE personnel, all district members, and all district staff.
I was interested in that. Why the WDE members and their families?
Mr. Chairman, Mr. Co-Chair, that was just, we just happened to be part of what they could offer to us. Whenever, we're the first full state implementation that they've done. So I tried to ask for what we could.
Laurel's had her finger in here a couple times. Go ahead.
Mr. Chairman, the Care Solace contract, they're really focused on connecting like a parent, student, whoever, right, with counseling services. It's not really like all the other all the other wraparound services. It's really focused on finding the counseling services.
Very good. Proceed. Go ahead.
Next slide, please. Okay, so when we talk about school-based mental health and how you implement school-based mental health, there's really two pathways. This came from SAMHSA and MHTCC, which are federal partners. They're kind of leading the way in what school-based healthcare can look like. So what we did was there's two real ways that you can go about this. You can do hiring actions within the school district and work to boost and support your personnel within the school district. Many school districts have these vacancies open, and there's a lot of problems with recruitment, retention, things like that. And that's not unique to the school district. That's just part of healthcare currently in the state of healthcare. Now, the advantages of partnership is you're creating a MOU type structure, and then you're utilizing that partnership to see students. The other big part of this that I found is really exceptional whenever you go into the partnership model is you're actually leveraging all of the infrastructure that the behavioral health organization has. You're leveraging their electronic medical records, their patient bill of rights, all of their infrastructure and support. You have access to their record management services, all of those pieces play a factor. So we've really built out the advantages of partnership. Next slide, please. So when we look at PTSB, PTSB has 421 school counselors that are active standard educator licensed. These are your traditional school counselors. Now, in addition to that, there's 7 school counselors that have active exception authorizations. These are one-year preparatory programs for becoming a school counselor. And then lastly, there's 14 school counselors that are on active internship permits. And the idea behind this is the 14 moves into the 7 moves into the 421, and that's your total workforce that's registered and regarded under PTSB.
Go ahead, Mr. Chairman.
I was trying to make that jive with your next page where your school counselors are at 308.
My apologies, could you say that again, sir?
So on the next, on your next slide, you show total workforce, you're showing school counselors at 308. And that, so I was trying to understand the difference between the 421 and the 308.
Yes. Mr. Chair, Mr. Co-Chair, if we'll, on this slide right here, so this is actually referencing from your state licensure. So the 541 total staff is reflective of the 421, 7, and 14 total on the previous slide. So we're talking about the difference between the Professional Teaching Standard Board's license versus the state licensure. So it's kind of all inclusive. There's in addition to the 421, we have about 120 other individuals that are licensed through state licensure.
Yeah.
And the reason that is, if I'm correct, is they can choose one or the other.
Correct.
And it was a bill we had 3 or 4 years ago in corporations because people started at different times and there are different requirements for continuing ed. And we finally agreed just to let 2 separate paths to being a school counselor, being in the system, depending on the license, because it big variation between school districts and population centers and what you need and who's currently there. So it does seem a little odd. You can be licensed by the state or be licensed by the PTSB.
I see, kind of.
That was good. You cut Chairman Swanter with his mouth full. That was
Yeah.
very good.
Thank you.
Mr. Chair, Representative,
Thanks,
thank
Dan.
you. That was articulated far better than mine.
Go ahead, Mr. Brown.
So what I'm trying to say here is the school districts can't do it alone. The healthcare organizations can't do it alone. When we drill down to what the recommended counselor, social worker, psychologist looks like, we're looking at ratios of 1 to 250 students for your school counselors and your school social workers. School psychologists, the recommended ratio is 1 to 500. Now, this came from the state legislative guide for school mental health. All of these legislative guides go back to the professional organizations, the Association for School Counselors, the Association for School Social Workers, and school psychologists. So these organizations are where these 1 to 250, 1 to 250, and 1 to 500 ratios originated. Now, when you look at our ratios, our school counselor ratio is 298 to 1. That is our closest ratio of the 3. With our school psychologists, we're 1,000 to 1. And then our school social workers are 652 to 1. So again, this goes back to reinforcing the ratios that we're at a point where the schools can't do it alone, the healthcare organizations can't do it alone, our community organizations can't do it alone.
Somehow I knew you'd have a question. Go ahead, Chairman.
Well, and because all of this is just, the numbers are really important, and I just want to understand it, because I think we have the funding model at 250 to 1, right? So they're funded to meet that, but they just aren't. And that could be for a variety of reasons. So when we look at this 298 to 1, doesn't necessarily reflect the fact that it's not funded. It's just that they may not be available. Is that a fair statement, or?
Mr. Chairman, co-chair, yes.
Mr. Chairman,
Go ahead, Laura.
I want to be clear that the funding model is only funding at the secondary level. So they're only funding the 1 to 250 at middle school and high school. They are not doing it at elementary levels. And a lot of the schools need support at the elementary level.
So then is this 298 to 1 reflecting the elementary school levels, or is it middle school, high school?
Mr. Ra- I think you have
Mr.
to answer that
Chairman,
one.
it's all inclusive. It's reflecting our student population.
Thank you, that helps.
Just out of curiosity, if you were to look at middle and high schools, are we closer to that 251, or do you know? Do you have that available?
Mr. Chairman, I can't speak to that intelligently.
Mr. Chairman, we were, Representative or Speaker Summers and I were trying to figure that out from the crew report, and we're going to have to go to our finance folks and figure out a little bit more about what is actually, where they actually are, because they're grouped with other folks.
Okay, go ahead, Director.
Next slide, please.
No, one second.
Oh, sorry.
Thank you, Mr. Chairman. Mr. Brown, can you please tell me what the difference is in terms of function between a school social worker and a school counselor?
Mr. Chairman, Director.
Go ahead.
Fundamentally, in a lot of circumstances, there's functionally no difference between a school counselor and school social worker. Now, they do have a separate skill set collectively between them, different training requirements, different credentialing requirements. But what you'll see as we progress through, the district utilizes the resources they have at their disposal at any given time. And so when students are in need, the line of defense that they have is the line of defense they have. And so the skill sets that they have are the skill sets they utilize.
Go ahead, follow up.
Thank you, Mr. Chairman. Mr. Brown, though, in some of the larger jurisdictions, so like Cheyenne, for example, it's my understanding that, you can hire whoever it is. So do districts show preferences for a specific type of skill set when they can hire, when there is an available labor pool between a social worker and a counselor? In other words, if I were a district, what would make me pick one or over the other if I were to hire? I have a vacancy, I have the choice, which would I pick?
Mr. Brown.
Mr. Chairman, Director, this is just speculation on my part. The district administration understands school counselors and the language of school counseling more so than social workers. We do have legislative statute that is stronger with school counselors and the school counselor-based skill set. And I think you actually see that reflected in our ratio, where we have a better ratio for school counselors because that school counselor skill set is better understood than a school social worker.
And I suspect that probably some of our administrators will probably address that when we get to public comment part. Laurel?
Mr. Chairman, just kind of building on a little bit on that too, the social worker rate also, while they're looking at mental, emotional well-being kinds of things, right? They're also making connections between the community and the home in ways we don't always see with counselors. School counselors are also, well, some of them very much have the ability to work with students in a more therapeutic kind of manner. They're also tasked with thinking about and working with career counseling and getting them through high school and some of those kinds of things, right? And they frequently end up with school scheduling for a school or the assessment scheduling. So they end up with a lot of other responsibilities like that as well.
Okay, proceed, Mr. Brown. One question, go ahead.
Thank you, Mr. Chairman. So having, I guess, looked at this topic, and I think there are some fundamental differences in licensure and skill sets that I don't think are being teased out by this conversation. But the thing I would point out is what I want to understand from the ratios, the suggested ratios, the way I read that slide is they should be additive, not one or the other or the other. They actually should be additive in this. And so when you take that into account, then I think there is no question, if you want to use the school funding model as the basis, that these professional organizations would, and what we're doing, we're providing for 6 grades, half of the thing. We are close to the ideal if you include the entire grade, which means schools are using other resources to fill in at the lower grades. But we are not accounting for anything of the school social worker or the school psychologist in the funding model at all. So we're underfunding and not funding for at least what these professional organizations would, at least my understanding is, would say is an appropriate level of service access. Thank you, Mr. Chairman.
Go ahead.
Well, and thank you, Senator Barlow, because I was wondering about that, because I thought in the Wilmarth memo where it talks about pupil support staff or whoever that could be, where it talks about it could be nurses and like that, that could include psychologists and social workers as well. Do I misunderstand that? So there's funding for them. Is that what you're saying? And it's just not, maybe it's underfunded? Help me understand what you said there a little better, please.
Mr. Chairman, I'm not going to make any assumption about what the school districts are utilizing or are utilizing the funding for. I guess what I'm trying to understand, I believe is the way I understand it, is these professional organizations would say these ratios are appropriate. I think they're additive, not one or the other or the other. So my argument is, I don't know if our current system, our model, contemplates that type of an additive system, except by having a catch-all of support staff, potentially, that a school district could utilize for that purpose. Mr. Chairman, thank you.
Laurel, go ahead.
Mr. Chairman, so the funding model funds the upper grades, 6 through 12, 1 to 250 students. It does not fund like behavior interventionists. It does not fund social workers. It does not fund school nurses. Like all those kinds of things are separate outside of it. The recommendations when they did the recalibration in 2020, which is kind of what the memo from Mr. Wilmarth was talking about, shows that there may have been recommendations like for school nurses, but the legislature chose not to fund them.
Go ahead, Chairman.
So I'm just a little bit confused, because in that document it says that you're saying that they're not funded, but the pupil support staff, the counselor and pupil support staff allocations would enable school districts to allocate staff across guidance counselors, nurses, as well as social workers and on. So it's not that they have the flexibility to choose what professions to hire with that allocation. Is that, or am I misreading that?
Mr. Chairman, I'm going to stop there for what I know of the school funding model. I'm not positive. I'd have to ask more questions on it.
Well, me neither. So that's why I'm asking, because I'm not sure that I know either.
A question to note.
Yeah, question to know.
Okay. Mr. Brown, go ahead and proceed.
Thank you. So this is our pyramid of tier 1, tier 2, and tier 3. The easiest way to view this is tier 1 is your foundational support approach. This is your universal screenings. This is suicide prevention for everyone, for all of your teachers. This is the Jason Flatt Act. When we look at tier 2, and something to always keep in mind with our pyramid, families are at the center of every interaction we have. Our consent process requires family support. If our services are right for the family, we bring them into our programs. There's no external guidance or direction from that. Crisis intervention for us begins as student needs exceed district capabilities. Where that typically occurs is within our tier 2 structure of our pyramid. Project Aware, we've been able to get students in within approximately 31 days for services. So the question comes in, what occurs for those 31 days? And I would identify to this task force that is one of the gaps that we have within our Project Aware, and a gap that exists within school-based mental health. We've identified the student, we've identified that they need services, and we've found them a partner for those services, but we have a month before we can actually get them into those services. So, everything you're thinking right now that can happen in those next 30 days are all realistic possibilities of what can happen in those next 30 days. We can go into full-on crisis. We can have the situation resolve itself. We can have the family get cold feet and decide that these services are no longer right for them. We can have clinical progression of the need for these services. All of those things are likely to occur. As we move into tier 3, our tier 3 is in fact those one-on-one clinical services. So I would pause there if anyone has any questions or comments before we jump into the next slide.
I would comment there that in the subcommittee, we spent a little bit of time discussing here in some of our school districts, Representative Summers and some of our school districts, a lot of these counselors who we don't have enough of already are spending a lot of time in tier 2 and going crisis to crisis. And that we end up underutilizing tier 1 because we spend too much time solving crisis and they never have time to do the other things that they need to be doing because we have so many students progressing into that. So that was a big issue.
Yeah, Mr. Chairman, that's a great point.
Further questions? Go ahead, Director.
Thank you, Mr. Chairman. When you talk about the 31 days, can you give some reasons as to why it takes that long?
Yeah, Mr. Chairman, Director, we actually have a range between 16 days and 39 days. A lot of this is workforce availability, what we're looking at. What I've done specifically within our model is there are places where you can hide students from and I say hide from an administrative perspective. We're not actually, Johnny, you go over here, we're going to keep you out of the way. But it's administratively, when you go from the detection of need to assessment to first counseling services, whenever you're going from the request for services to the assessment, you could theoretically measure your access there and get a false measure of your access. What we've done is I've designed the program to give us a true measure of access to see if we can do it faster than the external communities and the surrounding communities there. And what we've been able to do is get it down to 31 days on average, again, with that range between 16 days and 39 days. With mine, I have confidence that we're not measuring access at the wrong points. We're measuring it from a request, but there are some natural flaws that, we've discussed previously with measuring access. It's not the greatest measure, but it is the measure we have.
Okay, proceed.
Yeah. So on this slide, when we're talking about tier 1, tier 2, and tier 3, this is where we're talking about external referral outside. We are, the content that we just talked about previously to this, it was a lot more intense. The students that need that upper level echelon of services, this is not that. This is really truly Project Aware stops at that need for one-on-one counseling services. When it exceeds those, our referral pathway create a pathway to those external services that are needed. And we use that frequently based on student need and student demand. When we look at our tier 3, we're actually looking at a percentage between 1% and 5% of the students in a given population will need those services. And what I really want to highlight here is that students don't start at tier 1, move into tier 2, then move into tier 3. There's not a natural progression like that. As we progress in here, we're going to talk about fluidity. When we recognize the need within a student, it might be at the need of intensive outpatient treatment. When we recognize the need of a student, it could be one-on-one counseling. It could be as a student's transitioning from middle school to high school, that life change could warrant tier 2 service interjection. And that could be our starting point. But the goal is to always bring the student back to the universal supports of tier 1. Our tier 2 has approximately 15% of students at any given time there. And what we're trying to model is an 80-20 split between what the school district can provide and then external to the school district. Now, this is something we're trying as part of our model, but there's not a definitive answer in the research for what the correct percentage for schools to work with versus external providers. That's just where we're kind of launching at for our prototype. Next slide, please. So this actually shows the resource allocation distribution of Project Aware. You see our various funding lines. We have Thrive is within here as a tier 1 universal support at 100%. What you'll actually notice with our resources is it's not actually a pyramid. When we built these projects, we also tried to take care of immediate needs. So, you can almost visualize this based on where our resource allocation is as an overflowing cup. Because that's truly what we're dealing with our student populations is we have this overflowing cup of need. We're still trying to figure out how to get tier 2 correct with group counseling services, and recognizing that the student need of intervention begins in tier 2. And again, recognizing that 31 days is where we're at with Project Aware for those needs to go. So that gap is substantial to fill. Now, the tier 3, these are the resources that go directly into our one-on-one individual counseling services with our MOU behavioral health partners for our district. So, you'll see in there 55% for TIS. MHSA is actually 96%. We'll get that typo fixed on there. And then Project Aware is at 37%. Project Aware was originally built to build infrastructure. So we see a little bit difference with our Project Aware grant as opposed to TIS. Mental health, substance abuse, and Care Solace care coordination is really housed in that tier 3 sphere or the top of our pyramid.
Chairman Larson.
Dustin, can you, and I know I seen it someplace, but Project Aware typically takes 31 days, but prior to that, were we like around 60 days or?
Mr.
What was that
Chairman,
number?
Co-Chair.
To get services, once they were identified, it was much longer that we've whittled that down. It may be more than what we want, but I think that what they have found through Project Aware is that we've improved that.
When we did our initial proposal, the area that we referenced, it was 64 days was how long it was taking to get students in for routine, non-urgent, non-emergent services. So everything that's in our bread and butter of we match up a student with a counselor and start providing those counseling services. When we're looking at that same model in the communities that we went into, we were looking at a 64-day window for that. And so we've gotten to 31 is where we are.
Very good. Proceed.
Okay, next slide, please. Now, this is the complexity. These are kind of what we were talking about prior to me coming up here, is we have the complex services, we have inpatient services, intensive outpatient. Project Aware really stops at the bottom of this tier 3 pyramid that we're looking at here. Now, I say that this is actually going to take care of the vast majority of the students and the student needs within our district. And not to say the higher up you go, the more intensive the resources get. When you're talking about complex services for 15 or 20 students, those can become very, very costly when we're looking at one-on-one services or greater ratios. Routine counseling services are typically held on a weekly or a bi-weekly schedule. Group sessions are typically held on a weekly schedule within Wyoming Project Aware. And so with that, we can have students in, say, receiving counseling services once a week or once every other week, and in a group session to provide additional support for them. So that's really what I want to focus on, is that the complexity and the fluidity of Wyoming Project Aware, we don't have an answer for where our graph starts with intensive outpatient services. That's a limitation of our model, just based on the funding capabilities of Wyoming Project Aware.
Question.
Go ahead, Chairman.
Dustin, are we in categorizing the BOCES that handle these kids in the same, are they licensed similar to PRTF or an RTC?
Mr. Chairman, Mr. Co-Chair, I can't speak to the licensing of PRTF versus BOCES.
Director Schmidt can.
Okay.
Mr. Chairman, under the Department of Family Services substitute care designations, we don't necessarily split out and say RTC and BOCES, but we license BOCES as RTCs.
Thank you.
Okay, proceed, Mr. Brown.
Okay, next slide, please. So our logic model, we created a logic model in 2020. And what we developed was 4 outcomes. 4 outcomes that our work is all progressing towards: increasing access to services, increasing each student's family's knowledge of mental health and substance abuse, increasing the LEA's capacity to recognize and refer mental health and substance abuse needs, develop state-level infrastructure to support LEAs. Why we develop these needs is we've recognized at every opportunity that the district has a finite skill set. They can provide services up to a certain level, and then they need external support to provide those additional resources. So, like I said, we're doing a lot of things. We're doing a lot with our prototype to figure out exactly where that level is. But we recognize that there is that level there. Again, with access to services, going within our communities to a pretty significant, and the significance, I do want to reiterate that 64 days that we talked about, there's states out there that we're not talking about 64 days. We're not talking about a 2-digit number of days. We're into 3-digit number of days before students can get in and receive services. So when you look at us nationally, where we have a community that's at 64 days, there's both good and bad to that. We're still doing well in a lot of our communities nationally, but 64 days whenever you're in crisis is a lifetime. So I want to point out both of those. And then something we found is families are ready to engage. A lot of times they don't have the skill set necessary to support their child. We can probably all sit here and talk about our personal lives. I'm working with it with my children right now is, what level of intervention is necessary. And I'm a healthcare administrator with 15 years of experience asking some of the same questions. I would say these are important outcomes for us.
Mr. Chairman.
Dustin, in your research, I was just trying to understand the juvenile detention, in which maybe we don't have those around the state, so some might just be county jails. Do we find in these situations, when they're there, have they committed a crime, or are they able to place them there solely because they think they need it for their own safety?
Mr. Chairman, Mr. Co-Chair, I can't speak intelligently to that because my Project Aware actually stops before we get to that criminal justice intervention.
Sorry, didn't mean to get off in the weeds.
No, I'm sorry.
Go ahead, Director Smith.
Mr. Chairman and Co-Chairman, and the question to Mr. Brown, though, is when you have a youth that's in that top tier, but the bottom level of the tier, how often is it that you're experiencing behavioral issues as part of what's going on that then results in some sort of citation by a school resource officer or some other law enforcement is brought in, not because of the services they're getting, but because of the behaviors they demonstrate? And is that a potential then for how children move out of the school system then into a detention facility?
Yeah.
Mr. Brown.
Mr. Chairman, Director, I think what you said is very real. It's a school to prison pipeline, the construct of the school to prison pipeline. And with districts that don't have strong recognize and refer processes or policies or the capability to do that, usually where you see is behavioral outbursts, and that leads to the behavioral outbursts have the potential to lead to corrections-based interventions and things like that. So that is that's something very real and tangible that we struggle with here in Wyoming. Those behavioral outbursts lead into those areas.
Okay, proceed.
Okay, next slide, please. So in 2020, in September 2020 and September 2021, with our 2 cohorts, we did a student survey. The survey was a collaboration with our program participants, so our 6 initial districts. What we did with the development of the survey is we wanted to align our survey as closely to PNA and the former YRBS surveys, where we didn't have we didn't have strong outliers, but we were able to ask them. Now, part of our survey construction, we actually included thought partners of our students' families, administrators, teacher groups, school counselor groups. We got their feedback and we actually took questions out, added questions. We wanted to have something front-facing that would give us good Wyoming data as opposed to some of our national-based surveys. Next slide, please. So what we saw in our 2020 cohort was we got a 79% overall response rate. What that is grades 5, 7, 9, and 11 is who we surveyed within the survey. With grades 5, we did an active consent process. So the active consent process was we sent a letter home to the parents and asked them to return it signed, and only those student parents that signed for the survey completed the 5th grade survey. For 7, 9, and 11, we did an opt-out. We had our survey readily available for 60 days in all of our districts, and actually our survey is up on the Wyoming Project Aware website right now, so it's readily available to our students and to our communities. In 2021, we had a 70% response rate, again with those same groups. Our goal is to measure changes over time. So this fall, we're actually going to get our first look with the 2020 cohort with their year 3 execution of the next survey. Next slide, please. So our survey has 3 sections: student life. We wanted to measure the relationship with peers as well as adults. We wanted to measure how students are spending time outside of the school footprint, and we wanted to measure student support networks. That was what we were trying to measure with student life. Next slide, please. So these overall are a good representation of a baseline of where our students are at. When we look at 2020 versus 2021, there's no significant outliers. An adult I know believes that I will be successful, 89 and 88%. I would actually suggest that the other side is where we have concern. The 11% or the 12% that aren't answering affirmatively, that an adult I know believes I will be a success. This is indicative when you look at prevalence rates, when you look at the student need for services. A lot of times you're looking at this side that doesn't respond in the affirmative to these survey instruments. A student at my school can help me when I'm having a hard time. We got a lower response rate than I think we would all hope for with 70% there. Next slide, please. Now, when we look at activities, this is just some additional information, how our students are spending time outside of the school footprint. Sports teams, sports in the community, clubs, organizations, outside of school, clubs and organizations, hobbies, work for money, none of the above. So just a reflection of what we're seeing as a baseline measure. And next slide, please. Now, exposure to bullying, we have in our 2020 cohort, we had 13% express bullying. In our 2021 cohort, 19% reported experiencing bullying. In both cohorts, the most common response that we received on bullying was someone said things about me to make other students laugh. And so with our survey, we have some predetermined standalone choices, but then we also have a write-in option, and that was where we got these were written in. And then on mental health section 2, we wanted to measure students' knowledge and perceptions of mental health. We wanted to measure social stigma, and we wanted to measure coping mechanisms. Next slide, please. So when we look at this is where we start seeing where our tier 1 could be improved. At my school, I've learned about mental health. My school encourages students to take care of their mental health. These are reflective of our baseline within these 6 districts again. Next slide, please. So with this, the importance of this slide is that roughly 20% of our students don't know where to go whenever they need mental health support. And this is I would say, please keep in perspective that when we did these surveys, these districts, they had only been up and running with with funding for about 10 months of programmatic funding, and we've only been doing Tier 3 clinical intervention services for 5 months at the point these surveys were administered. So I think it's a good representation of where our students were during this time of survey. Next slide. Now, our last section, substance use and abuse, we wanted to look at visibility and stigma, students' experiences with vaping. We targeted vaping specifically because of the rise in prominence just pre-COVID and into COVID, and then students' knowledge and perception of substance abuse. Next slide, please. So again, here we see approximately 20%, not at all true, a little true, about how much they learn in schools. So I think you're really measuring perception here. The perception of potentially the effectiveness of our Tier 1 structure. Next slide, please. Now, the concerning piece on our electronic vaping products is the no and the I don't know. Those pieces are here, and we're interested in what kind of data we'll get on the next one, but this is just kind of standalone for your knowledge. And so on this slide, the IPP indicators, this is actually a reference to our referral pathway. So the bottom part of this that you'll see is how students come in and then how they exit our referral pathway. So if we can move to the next slide, which is our access. So we've been able to serve approximately 67% of the students that have come through one of our referral pathways. To date, 819 of 1,230 students referred have been served. Now, that is external to our Wyoming, the CDC Rescue Funds grant. We were able to serve approximately 400 students with that grant. So it gives us a little bit more data, but those projects didn't collect data, so it's just anecdotal. Now, with our training, we've trained 4,201 individuals within our districts. That could be QPR training, it could be youth mental health first aid. QPR is question, persuade, refer. It's a suicide prevention-based training. Character strong, sources of strength. These are a mix of evidence-based and trauma-informed trainings that we do for largely to increase the referral and recognition pieces of our program. Next slide, please. Now, workforce development, we actually shred out the number of licensed mental health professionals that we train as part of our training. And so of the 400 or the 4,200 individuals trained, 522 of those were mental health licensed professionals. Now on NAB1, this is knowledge, attitudes, and beliefs. When we do these trainings, we've started to measure how knowledge, attitudes, and beliefs change with a pre-post survey that is executed at the end of the training. So when we look at that, if we go to the next slide, please. We have 76% experience positive change. And I want to talk about that briefly. I think when we talk about the 76% experiencing positive change, there's potentially a misnomer in there, because right now we're still in the phase where we're training the enthusiastic individuals for these services. We're training our school counselors on youth mental health first aid. We're training our school psychologists on question, persuade, refer based trainings. So when you look at that, the knowledge base on these individuals currently taking our training is significantly higher than the general public. So I am interested to see more data as our processes continue to see what we get there. So I kind of wanted to caveat that 76% with some additional information. Now, again, this is our access to care slide. Again, our goal with Project Aware is 28 days. That was our goal. And again, our access to care is 31. And my apologies, I said 16 days earlier, but 19 days to 36 days is our actual range for access to care across our various districts. And we can go to the next slide. Oh, one more, please. So here we have, this is our theory of change. We're really trying to impact mental wellness, behavioral and emotional problems at age 3. were associated with performing below grade at age 12. Problems at age 12 are associated with a lack of complete final grades, non-eligibility to higher education. What we're trying to recognize within our program is that mental health is holistic. Mental health is family health, is physical health. All of these pieces play a part in mental health. And the sooner we can get in and provide intervention services, the sooner we can get in and recognize and refer to services that are needed, the higher likelihood that we have a better outcome. Okay. So this is our slide for CareSolis. We have one more after that, which is bullet points, which makes this a lot easier. On average with CareSolis, what they do is they do all those phone calls for you, so you don't have to talk to everybody. I know, I pulled my shoulder a couple weeks back, and I gave up with the VA at like 3 phone calls. I was like, somebody will eventually call me back or respond to my message on the thing. But it truly is. I think we lose so many people that need services with those phone calls, and so CareSolis is one answer to that for connecting our family resources. If we go to the next slide, these are the bulleted points that I really want to highlight. CareSolis provides care coordination, which matches the student and the family with a consent process where the family consents to those services with mental health and substance abuse. There's 2 ways to do this at the district level. There's a QR code, there's a link, there's a website. You can go to all those sources and you can anonymously go and refer yourself. District staff can go anonymously and refer themselves to these services. You can also use a warm handoff. That warm handoff originating within the school district, likely a school counselor to our community project manager, will then trigger the care match referral process. In which case the district can get a de-identified level of data back and make data-driven decisions on what is occurring within the district. Is anxiety prevalent right now? It gives them a level of real-time data based on the dashboards and the capabilities they can see. They can see what their students are largely being referred for. Is it life skills based? Is it soft skills based? All of those pieces play a part. And again, the CareSolis application, it covers all Wyoming students, all Wyoming student families, district staff families, WDE staff families. So it is, we're talking about the full 92,000 student population plus largely everyone associated with them. The annual cost for this is $375,000 a year is what we pay. And again, I do want to say some of the services that they offer are already provided by private insurance, or they're provided in a similar manner, whether it's through the mental health waiver program or other programs or other workplace benefits that could be out there. But this one is really specialized, as Dr. Ballard said earlier, towards that mental health and substance abuse component.
Chairman Larson, go ahead.
Who's paying for that?
Mr. Chairman, Mr.
Who's
Co-Chair.
paying for that? The
It's-
375,000?
WD, we've purchased through December 30th, 2025. We don't have an answer beyond that, though.
Was that through a grant or was that a general fund deal? What was?
Mr. Chairman, it
Go ahead,
was
Laura.
used through the stimulus funds, through the ARPA funds, that the department receives.
I just find it a little wonky that the WDE staff and families was included in that. That's just me, but it certainly doesn't send out a very good picture when other state families and other state employees weren't covered in that. I just suggest exercising caution.
Mr. Chairman, Mr. Co-Chair, I can definitely ask what it would look like to extend that to the whole state.
I like the word wonky. I'm glad you came up with that. Further questions, committee? Go ahead, Dustin.
Next slide, please. Okay, so lastly, we looked at measuring national outcome measures. So national outcome measures this is essentially the data we have to collect as part of the grant opportunity. So this data all goes back to our federal partners through what's called national outcome measures. So this can be demographic, this can be functioning, military family deployment, education, social connectedness. These are all things we're measuring. Functioning is actually one that we have enough data that we can share here with the group. So when we look at the next slide, the state of the data, we have baseline, we have 819 student assessments that we could have completed. The number interviewed is 693 with 130, where we've got at least 2 points of data. So when we look at that from the next slide, this actually gives you a good idea of what we're seeing within our student populations. Anxiety, 87 students. Now this snapshot is a current snapshot of what we're seeing. It doesn't reference back to the last slide, so I would keep that in perspective. This is what is actively being seen within our project right now. 87 students with anxiety. When you look at F32 and F33, these are both major depressive disorders. So depending on how you look at that, sometimes those are grouped, sometimes those are not grouped because you have single episode versus recurrent. We have attention deficit hyperactive disorder, and kind of going back to a little bit of our earlier discussion, conduct disorders. When we look at things, sometimes behavioral changes in conduct are one of the first things we recognize. So here's where our data potentially gets exciting when we're looking at functioning. When you look at baseline versus discharge, we are seeing positive results on functioning across our students within the program, where we again can measure that data. When we look at the top one, I get along with friends and other people. That's our instrument of measure, going from 80 to 88%. But when you look at the very bottom one, I am able to cope when things go wrong. That is a very substantial change when we're looking at 35% to 84% on there. And so everything indicates that our modeling is moving in a positive direction. I would never declare to you that it's the end all be all. I think there's, we've seen two ways in my presentation already that you can do school-based mental health. But 35 to 84% is it's an interesting measure.
Mr. Chairman.
I hear two questions. Let's hear Director first.
Thank you, Mr. Chairman. Just a question on this. Your in here is 129. Is this everybody who went through the program or just those that either selected into it or received services?
Mr. Chairman, Director, this is the 129 is the actual individuals that we have 2 points to measure. We have a baseline and a discharge point, so it's not reflective of everybody in the program, because with everybody, we don't have that second point of data.
Follow up, Mr. Chairman.
Go ahead.
So do you know the number off the top of your head of those that you don't have 2 data points on?
Mr. Chairman, Director, it's approximately 560 that we don't have 2 data points on.
Okay, thank you.
Mr. Chairman.
Dustin, if you could help me, I looked at this and I sense that it's something important, but I don't understand the chart. I don't understand what N equals 129, the percent agreement. I don't understand what baseline and discharge is. So for somebody that's not very good at understanding this kind of stuff, could you help me through that where I can understand it? And then I couldn't understand the comments to the left, I get, and then my child gets. So is that the parent responding or the child responding? Or
yeah, okay. Mr. Chairman, Mr. Co-Chair. So going to your first point on the data itself, I would say that we do not have statistical significance in our data, and I would not want anybody to take away the statistical significance with our data from what I'm saying here. We have what looks to be moving in the correct direction, the direction we would want things to move in. When we look at those measures, the survey is conducted, or the National Outcome Measures survey is conducted 2 ways. If the student is 10 or under, the parent is answering those questions for their child. If the student is 11 or older, it's the student that's answering those questions. The only instance where there would be 2 instances where if the student was 11 and older and wasn't capable of answering the questions, the parent could answer, or if the student was 10 when we started services, the survey requires us to have the same individual answer those questions as we go through. So that's why those survey instruments are worded with, I get along with friends and other people. My child gets along with friends and other people. So kind of two ways to ask that.
Okay. Very good. Go ahead and proceed.
And my last slide is questions.
That's the easy slide, right?
Yes.
You hope. You hope. Any questions for Mr. Brown?
Well done.
Director, go ahead, sir.
Mr. Chairman, just really quick, Mr. Brown, following up on my previous question. So, 129 respondents with 2 data points, over 500 where we don't know. Do we assume anything about those non-responses? Because you mentioned it looks like it's moving in the right direction. You see some increase in percentage or growth of the kind of responses we want to see, but just a lot of missing data in there. So do you anticipate getting those responses, or are they just folks that kind of fall off the radar?
Mr. Chairman, Director, what I've found is that as we've progressed through our program, once we do the initial intake and the initial data collection, what's occurring in our program is the healthcare structure largely becomes the dominating force. So the treatment plan becomes the dominating force through our program. And it's led to you see it as we progress through the treatment plan, that the 6-month interview decreases from the initial. We've got an 89-ish% baseline interview rate, success rate, and then you see us drop into the 50s and 60s with the 6-month interview, and then you see us drop to the 30s with the discharge interview rate. We're actually doing a continuous process improvement to look at how we can increase that, because our hypothesis is that when the treatment plan takes over as the driving force, the desire to collect the national outcome measures decreases. So I fully anticipate that we're going to have a better pool of discharge data in the coming years, but we're not there yet.
Further questions, committee? Thank you very much, Dustin, for presenting that to us twice now.
Yeah. Thank you for your time, everyone.
Okay. Committee, if you look in your handouts on the latest, I believe was version 4 of the electronic version, there's one more slide before we get to the subcommittee's recommendation, and that was the behavioral health pyramid. I think it's pretty self-explanatory. Laurel, would you have any comments on that?
Mr. Chairman, I think Speaker Summers had asked for this as a part of trying to figure out what's happening inside these tiers. He was definitely spending some time trying to think through, what do we do with these kids that are identified and then don't receive services for 30 days? Who's taking care of those kids? And I think part of what he was hoping that we could kind of pull from that is that really that the school tends to be the one that kind of supports those students with the families, in conjunction with the families, to kind of get the kids to the data service line.
Very good. Are there any questions, committee, on that behavioral health pyramid or any of that discussion? If not, I would take you to your handout on the K-12 mental health working group recommendations. This is the things we came up with at the end of the day in our bad seance, as I said, where I was in and out of this meeting. But this is what we came up with, and I will just read down through that for you. That we've all noted that there is stuff in the model. It's not necessarily being followed per se exactly. The state should pursue the mental health model, and the state has a role from Tier 1 until a child is referred and handed off to mental health services in the community. The gaps in the tiered model are as follows. There's a need for more resources on Tier 1. There are not enough school counselors, nurses, or psychologists to perform crisis intervention in Tiers 2 and 3 before a child receives a community mental health service. As I mentioned, they tend to be going from crisis to crisis. C, there are significant wait times for referrals for mental health services, leading schools to have to handle children in crisis for longer periods of time. Department of Education has a goal for wait time services 28 days. Actual time is usually longer. It's unclear when and how many services the state should provide post-referral to mental health services. Who should pay for those services post-referral? And finally, number E is sustain WD's Project Aware. seems fairly obvious that Project Aware is working. The numbers and the improvement was fairly significant. It's working. We just need to make sure it's funded and get it working appropriately. Number 2, there will be a school finance recalibration 2025. Task force would recommend that the counselors conducting the recalibration focus in part on mental health in public schools as well as on security and safety. Number 3, in the 2020 school finance recalibration, recommend a number of school counselors, school nurses be increased specifically, and I won't read through that whole thing, but that was something we talked about, what's actually out there and what's been recommended, and the ratios that we currently have don't meet those recommendations. And there, it just tells you to see the memorandum that everybody has in their handouts for Mr. Wilmar.
Questions?
Go ahead.
So my first question was, what was the conversation on item number 2 to include security and safety on top of mental health?
And that may be a part that I missed, Laurel. I don't remember the specific conversation there. That was a part where I was probably fighting my computer.
Mr. Chairman, I don't even remember that part of the discussion. I will tell you that what we do know is that there are safety concerns that go on in the schools, and it's that students will talk about just not feeling safe at school. That's as much as I know. I don't remember that part of the discussion.
I just think we need to be careful and stay focused on the issue, which is mental health and safety and security.
I suspect, Mr. Chairman, that it had something to do with those who are escalating in behavioral needs, and I'm just speculating here, and then making the other students. But yeah, I agree with you, is that it would probably best leave that out, any verbiage that we come out of here with.
And then a follow-up question, if I could. Is there any reason, help me on the tier 2, maybe Laurel, maybe you can help me on the tier 2. Is that all handled with, you're saying, does that need to be handled in school? Is it more appropriate to handle it in school, or could some of that be outsourced as well?
Mr. Chairman, so anything, we're talking about anything when you start talking about clinical or therapeutic services, at that point, that's when you kind of do the handoff. When you think about tier 1, right, that's all the things you do with everybody, the suicide prevention, right, those kinds of things. When you talk about tier 2, it's some of the kids that have additional needs and providing, so you can provide more intensive supports around like suicide prevention and those kinds of things, right? And so those kinds of things, they still felt like were perfectly appropriate inside the school. But when you start talking, as soon as you started talking about any kind of therapeutic or clinical type of services, then we're moving all of those outside of the school. Mr. Chairman, just as you're thinking through this, a lot of school districts right now are paying for some of that stuff. They are addressing it, but they're using their stimulus funds that will end in August of next year or September of next year.
When you say stimulus, is that the ESSER dollars?
The ESSER ARPA funds, yes, sir.
Okay. Okay.
Go ahead, Director.
Mr. Chairman, Dr. Ballard, in reference to the question about safety and security, do I remember correctly, I think it was in the beginning of this task force where we talked about psychological safety for kids who are afraid to go to school because of bullying, et cetera. Was that this conversation or was that a different one? Because I think that would matter in terms of safety and security, in terms of mental health issues, not just physical safety and security as we might talk about in other venues.
It's quite possible. I mean, we've also talked about, right, like if we have kids in the classroom and it's more a behavioral issue more than a mental health need, right? But they get a student get mad at a teacher, throw a chair at the teacher. Now the teacher's trying to figure out how to deal with the student that is clearly in some need of some additional supports and interventions in that moment while trying to keep the rest of her class safe. In the teacher retention and recruitment task force, they actually talked about, and one of their recommendations that we talked about this morning was that we add more behavior interventionists into schools, and funding some of those to help with the behavior pieces that are getting in the way.
Very good. And I'm just reading through here and I see something, and it'll segue us into the next section. In that number 3, and a part that I didn't read off, is that the recommendation from the working group is that a bill draft be created to fund those components categorically outside of the block grant to level consultants recommended in 2020 until those components in recalibration in 2025. And then it refers you to the memorandum by Mr. Wilmarth, excuse me. And I believe we had some questions. And I just, come on down.
So, Mr. Chairman,
Yes, sir.
I think the questions that, and it goes to this as well as back to the conversation on the professional staff that we talked about on school counsel, on psychologists, social workers. And Matt, as I read your analysis here, we had a conversation earlier where we was trying to figure out what funding was available for school counselors, and then there was some question. I thought I understood your paper to indicate that in the support staff of the K-12 funding models, the districts have the ability to use that for a variety of professional services, including guidance counselors, nurses, social workers, or et cetera. But if you could clarify that, because maybe I just misread or misunderstood it.
Thank you, Mr. Chairman and Chairman Larson. Matt Wilmarth, LSO Senior School Finance Analyst. With regards to the Education Resource Block Grant model, the counselors that are allocated under the formula are directly for the middle school and high school students. And they're generally just guidance counselors. They're not any mental health counselors. And this comes from the formula has not been changed since the 2005 recalibration. So it's been a constant allocation of resources since that time. During the most recent recalibration in 2020, the legislative consultants recommended additional elementary school guidance counselors, but that was not adopted by the legislature. With regards to the pupil support category, again, this goes back to the 2005 recalibration recommendation. One position was allocated for every 125 at-risk students, but with a minimum of one position at each prototypical elementary school and one prototypical middle or high school. That was modified in those positions, like you indicated, could be used for a variety of purposes. A social worker, a psychologist, any non-special education position that would support students based upon the needs of the district or the school. In the 2020 recalibration, the legislative consultants modified that recommendation to one nurse for every 750 students with a minimum of a half a position across the district. And then for the pupil support category, they actually decreased the allocation to one position, one pupil support position for every 100 at-risk students with no further amount for a prototypical sized school, whether it's elementary or middle or high school.
So is at-risk based on economics or behaviors?
Mr. Chairman, we define it as a proxy. In the at-risk proxy count is based upon the number of students eligible for free and reduced lunch under the National School Lunch Program or English language learners. And then in grades 6 through 12, students who are what we consider mobile and that they move their school in grades 6 through 12. And it's a unduplicated count, so the student who is both free and reduced lunch eligible and an English language learner is only counted once. It does not necessarily mean those are the students that will be served, but it's a proxy to generate resources, to generate the population of a school that may need those resources.
Follow up?
Go ahead.
So do you have a feel, or maybe Dr. Ballard would know this, in those, for that funding for those positions other than counselors, where we said could be nurses, psychologists, social workers, do we find that the majority of the time that is a school nurse, or do we have a feel for, has that changed any? What do they typically, what do the school districts typically reach out to as a priority, or I don't know?
Mr. Chairman and Chairman Larson, if I'm understanding your question, is you want to know how districts are actually allocating those resources as opposed to what's being allocated through the funding model? Is that your question?
Yeah, I'm just wondering where they're using those funds for. Is it mostly nurses, or is it mostly social workers? Is it mostly, what is that mostly?
Mr. Chairman, I'll have to look at the data, and I can certainly access the data from the Department of Education to estimate non-special education staff being utilized in the manner as envisioned by the block grant, and compare how districts are allocating those. So we can certainly compare how many guidance counselors are being hired by a school district as compared to what's being allocated under the block grant. And then the pupil support, there's not a position in the Department of Education staffing collection that says pupil support. We'll have to make some judgment on, we'll include nurses, and we'll include school psychologists that aren't special education, social workers. So we can certainly work with the Department of Education based on their staffing collection to identify what they feel are the appropriate crosswalk staffing categories that would be considered pupil support. And we can certainly report that data back to this committee or this task force.
Thank you.
Thank you. That would be useful information. Further questions for Mr. Wilmar? We appreciate you coming down.
Thanks.
Thank you very much. Committee, comments before we go to public comments, suggestions, ideas, proposals? Hearing none, let's move to public comment. Anybody here who wishes to publicly comment? Ms. Semino, welcome.
Mr. Chairman, members of the committee, Lindsay Semino with the Wyoming Counseling Association. I just want to highlight some things that have already been discussed that I think are going to be important as you guys think about your recommendations moving forward. I did send the legislators, forgive me, department heads, a Venn diagram of the different roles within schools as far as school counselors, school psychologists, things of that nature. If you have any additional questions, I know that the presenter before me also covered a lot of that. And I also have it ready for LSO if that is something that you guys would like to discuss. As far as the differences between school counselors and school social workers, is that something that I am seeing nods from the chairman?
Enlighten us, please.
Lovely. This was actually given to me by the Wyoming Education Association, so I would like to give them credit, as this is something that we've been in discussion with them a lot. When it comes to really the difference between why a school district or a school would hire a school counselor as opposed to a school social worker, the big difference that we see in the very tiny print is that we see school social workers a lot within K through 6, and we see school counselors a lot in the secondary education. And that is because the school counselors do a lot more assessment and behavioral plans within K through 6. Whereas in secondary school, though it's not uncommon to have testing, it is more common within the K through 6. So we see more school psychologists, more school social workers within K through 6, whereas school counselors can be more within the secondary schools doing the scheduling, the academic standards, things of that nature.
Question?
Question, quick. Go ahead, Mr. Chairman.
So Lindsay, the school counselors, the ones you talk about, the guidance counselors, if you will, how, and I understand the need for what they do, and I'm not talking about that, but is there training to that point? Does that allow them to function similarly as, say, a social counselor, somebody in your world counseling? And if not, to what level? I'm trying to get a feel of where their comfort level is in this increasing need to intervene in the school, if that makes sense.
Ms. Semino.
Mr. Chairman, Representative Larson, for point of clarification, you mean for the counselors specifically, or are you wanting that for social workers as well? Mhm.
Intervention in helping people, the kids to cope and make corrections, but to what capacity do the school guidance counselors have the ability to do that? Is, I guess, my question, if that's making sense.
Mr. Chairman, Representative Larson, my response to that will be it's going to be based on the counselor. The majority of our school counselors are dual licensed underneath the State Board of Education as well as with the Mental Health Licensing Board, meaning that they do meet qualifications for both. So that means that your school counselors that are dual licensed are also clinically trained. Those who are clinically trained are going to feel more comfortable with that. Those who are not dual licensed, I cannot speak to whether or not they would feel comfortable with that. So it would depend on that counselor's background and where they're located.
That would be another number I would be interested in seeing. How many of our school counselors are dual licensed and how many are not? Okay, further questions from Ms. Semino? Seeing none.
Mr. Chairman, other things that school counselors do is student advocacy, orientation and transitional services, and also a lot of records, and we talked about schedules, as well as guiding curriculum and making sure that there's, effective presentation for the education and the instruction within class. Some other points that I wanted to highlight in regards to this discussion, it was talked that community providers, it was mentioned within the presentation that community providers have a caseload of 35 to 40. That is true for providers that are connected with community mental health centers or within group facilities. For those individual providers who do everything on their own billing, answering their own phones, their own emails, cleaning their own offices. The rule of thumb is actually 1-to-1, meaning for each hour of clinical service that you're providing, it's 1 hour of administrative. Therefore, a lot of our individual private providers, their caseload is somewhere between 20 to 25 on average. The question that I had while listening to the presentation about Care Solace was if whether or not, or the concern that I had was whether or not providers know that they need to register for Care Solace. The network seems incredibly easy. I looked it up while we were discussing it this afternoon. It was incredibly easy for me as a provider with an MPI number to get signed up and to become a verified provider for Laramie County School District, which I completely did in the time of this presentation. But how well is that known for our providers across the state where Care Solace is being offered? Do they know that they need to register? Are districts making that happen? Is that something that this board wants to look at? And then finally, I would like to touch on security and safety. There was a lot of stipulation for you guys. I was not at that meeting. The way that we read that was from a clinical standpoint was safety and security in regards to any type of self-harm or suicidality. We do know that in our smaller districts, they may not have protocols for if there is a student who does attempt any type of self-harm, and then how the staff would respond or the community would respond appropriately. So though I know there was some speculation as to what that meant, and the good chairman wanted to make sure we stayed on task, I feel as though that would be a way that this falls underneath that umbrella. So I just wanted to put a plug out there for that. And I stand for questions.
Questions, Ms. Semino? Nope. Questions? Thank you very much, Ms. Semino.
Thank you, Mr. Chairman. Thank you for all of your work on this. We're really grateful that this committee has taken this as a focal point.
Thank you. Further public comment? Another familiar face. Welcome.
Chairman, thank you. My name is Dan Mayer. I'm the Executive Director for BOCES 5. I just have a couple comments on the recommendation sheet. And I'm going to tie into the comments that were previously made, and I'm going to start where she ended. On item number 2, in regards to the conversation regarding mental health and the school and safety, from my experience in those conversations, when they looked at recalibration, they looked at school safety, they focused oftentimes on hardening the school. And I think a lot of comments from the field came in to saying that we need to add resources, right, to, so we see that we do a lot to protect the school and harden the environment, but what are we going to do when the threats and those concerns come to us in that environment? And so I think they are, as the previous speaker talked about, that those two are related together. In addition to, when we talk about safety oftentimes equals into anxiety, we were discussing. And then that was the number one identified need in the previous presentation is anxiety. And I think just safety is one of those things that creates anxiety. So I see when we talk about school threat, we need to take a look at the mental health side, because sometimes those two are interrelated, and that's where I see that being connected. On item 1, when it addresses it's more probably confusing, just needs to be clarified. The state should pursue a tiered K-12 mental health model provided by the Department of Health and Department of Education. The state has a role from tier 1 until a child is referred and handed off to mental health services in the community. And I think that the school has more of a responsibility when those services are I don't think it's a handoff. I think they stay involved in those services throughout that time. And I think we need to be able to support. I think we need to find out where the gaps are and build bridges to work together. So these handoffs are soft. It's not now this is your responsibility. This is a team effort. And I heard sitting in here, there's a lack of resources. We need to figure out how we build resources in our community. So when it gets to a point the school can't handle, there's something to hand off to. And so, under A, there's more resources at tier 1 that are needed. The final thought is CSTAG is another example. We have this Safe School Alliance grant where we have the comprehensive school threat assessment training that we are providing. And that would be another avenue so it's a crisis prevention model. So when children make threats, there's a model that can be referred to. And Dustin's presentation would be an access to be able to provide those resources. If those two concepts would be melded in the school, we're teaching schools how to respond when they get threats, and then refer off to a handoff. And it would be nice if Project Achieve and these other initiatives were more aligned and could be communicating with each other as they're trying to serve oftentimes similar clientele. And those are really my comments on the recommendations, and I'll stand for any questions.
Very good. Chairman Larson.
Thank you. Dan, if you can help me, because you left me a little confused, because you referred to the handoff and you said there shouldn't be a handoff, but then you went on and referred that there should be handoffs. And that's fair, but I just want to make sure that I understand you correctly, because what we're talking about is the mental health services and who's going to provide those services. And so I want to make sure that I understand, do you think that as the community is providing those services, that the schools should be providing those services in addition to that? Help me, walk me through that.
Monitor that student. That student's going to return when they go to a community service, right? It's like when we provide medication, if I would have a disease or I would have some infection, I would take a high dose of antibiotic for a short period of time, and then I would maybe go to my standard course of treatment. I guess the way that reads it seems like it goes to someone else. I think I'm promoting a more integrated system and looking at where they are and how are we communicating and working, and thinking of the system of care and supporting that to make sure that kids are supported across the entire system. And when you read that, it seems like someone else is going to take over, where I think that entity should stay along through that, even though there is a handoff, but they're still involved in that student's programming.
Mr.
In
Chairman.
my mind, this takes the form of, like, when I refer a patient to physical therapy, I refer the physical therapist, I send a letter, I send a note, and then the physical therapist, after seeing that patient, then sends me back a letter, says, here's what we've done, here's what we accomplished, and then we work together down the road. That's what I envision.
Yes.
I think that's what we're saying.
Yes.
Mr. Chairman.
Yes, go ahead.
And I think we have that in the Project Aware, right? So we have what we call our community project manager. And Mr. Brown, if I get something wrong, let me know. And that's part of their role, is to do that coordination and making sure that if kids stop going to counseling, they know what's going on. They can work with the parents to figure out, if that's what they want, if they need to go to a different counselor, all of those kinds of things. And so that's, the Project Aware definitely has that built in. And I believe that, Dan's right. You absolutely need to have that kind of coordination as we go through this and supports.
Agree. Further questions? Go ahead, Rick.
Mr. Chairman and Dan, one of the issues, or one of the topics that I haven't really heard covered much in terms of this conversation is around special education and the role of special education. We're talking about mental health, certainly through Project Aware, but with those students that come in with special education needs that are oftentimes co-occurring with intellectual disabilities and developmental disabilities. So as a provider, Dan, who understands the intricacies of special ed in relationship to mental health issues, relationship to behavioral health issues, where is it that you would see special ed coming in these tiers or in these handoffs or what have you?
That's a great, Chairman.
Go ahead, sir.
Director Schmidt, that's a good question. Not every student who would access would be qualified for special education. So first, they would have to qualify independently of that. And I think that's always the difficult juggle, is that we're going to have students who are, will come through general ed and special education. Where special ed needs to come in is at the earliest point available, because free and appropriate public education for students with those identified needs are at the utmost important. A lot of times you see that level of service at a tier 2 or a tier 3. But definitely throughout the students, I can see students who are identified special education who may need access to those services at that tier 1, tier 2, tier 3. Special ed, I think, just complicates it, and where that blends in with that, hopefully I'm answering your question, or.
Further questions, committee? Thank you very much, Dan.
All right, thank you.
Further public comment? The seat's warm, jump up there. It won't stay warm long. Further questions, further public comment? Anybody online, Katie? Nobody online, that's because there are no warm seats online. Committee, that brings us to discuss this, make any recommendations. I would note for the committee that one thing the subcommittee did recommend is that we have a bill be drafted to fund these components. And I would add to that, not just fund these components as in the model, outside of the model, but to include K through 6. Not just 6 through 12, but that we fund this all the way K through 12 and see if we can more appropriate that. And that would be, I would just throw that out for discussion. If anybody wishes to entertain that, I think it's a worthy thing to entertain and discuss again in our September meeting. but that's at the whim of the committee. Committee comments, discussion about what we've talked about on K-12. Chairman Larson.
So I think it's appropriate to do a bill draft. I think that there's a lot of conversation yet that needs to take place on that, particularly on, but until we see the bill draft, it's hard to flesh that out. On the task force would recommend the consultants on the recalibration focus. How do you envision, who are we recommending that to on number 2? And I think I would suggest that we need to clarify what security and safety means. I think we heard 3 or 4 interpretations of what that is, and if we go to major maintenance statutes, we can find it again. But when we talk about recalibration, we're really talking about positions and funding. And so I think we need to clarify if that's in the physical asset, meaning the buildings, to make sure that there's, or if it's, I couldn't track it. So I think we just need to define that a little bit.
And I believe that may be in the way that it's worded.
I do too, but if we could do that. But then, what was the, is this back to joint education that we would recommend this? Is it to maybe chairman's not here, that maybe that's appropriations?
I would propose that we draft it, or that we make a recommendation, or make a letter of recommendation to the Joint Education Committee as that school refinance comes back up, or perhaps to Appropriations and the Education Committee, but specifically to the Joint Education Committee. And then through that process, we can work on the wording of security and safety.
And then I think we need to define a little clearer as we make these recommendations, when we say there needs to be more resources for Tier 1, is that coming back to the calibration model, meaning the number of people, or the more, I think we need to define what that is a little more extensively, so we can, and it may be multiple things, but I think we need to identify what those are.
Yeah, I think my guts tell me, Mr. Chairman, that if we do that bill draft, that's something we can flesh out as we discuss the bill draft. We can decide what those needs are and talk about that. But
thank you. Those are just my
comments, committee. So with that in mind, I'm going to ask LSO if we can draft a bill and include K through 6 in addition to 6 to 12. So it's K through 12 on those recommendations, and we'll talk about that September 28th. Is that something like that? Here, I believe. Okay, further recommendations, committee ideas. Question, go ahead. Chairman's watch.
So, thanks, Mr. Chairman. So when we're discussing this, does it cover all of the kids that are in like the boys and girls school, or kids that are in BOCES program, or and should we expand? I guess I'm trying to figure out how we incorporate, because when kids are too, let's say difficult, it's not the right word, but closely, and they're going to some kind of specialized program, I mean, they're still YMIS, they still need services. I don't want them to get lost, and I want to make sure there's still coverage for them as well before they get to the point we have to move them out of state or we don't have a facility.
Before we do that, let's walk through how that funding stream goes now. So Director, would you mind telling us how that works?
Mr. Chairman and Mr. Co-Chairman, so funding for youth or children who are placed in state custody. So let's make that distinction first. These children are placed in state custody, so that means that there has been a petition filed with the court. That can be a petition due to abuse or neglect. It could be a petition due to a delinquency, meaning a crime committed by the youth or child, or a child in need and supervision. And it's that child in need of supervision petition, CHINS, that's usually the vehicle for children who are in school, who maybe are showing behaviors whereby a higher level of care needs to be provided. Okay, so if this gets a little bit complicated, back to Mr. Mayor's conversation about special ed, because that plays into this as well. But if the child can be taught, can get its educational needs met at school, but for whatever reason, there's behavioral issues. I can't remember exactly what the statute says around chins, but it's absenteeism, it's incorrigibility, I think it's basic, runaway. It's basically those naughty kids that then the county attorney, district attorney would ask the court if they would accept a petition for a CHINS child. Okay, so once they get into our system, in a lot of ways, that distinction doesn't matter anymore. In a lot of ways, not in all ways. So you have a child then through one of those petitions is placed into the custody of the state. Then the state, through its multidisciplinary team around that kid, so there's a team that's created around that family that says, what is it that this child needs? If that MDT determines that that child needs a placement for therapeutic purposes, mental health purposes, et cetera, they first need to say, what are those needs? What is the level of care that would be appropriate for that youth? If that youth needs a very high level of care of a psychiatric residential treatment facility, that is a Medicaid service, and that service is medically necessary. So a doctor would have to say this child needs a PRTF level of care. Then Medicaid negotiates through their rate with that provider on the educational services. So in that placement, educational services are paid for through the Medicaid rate. Okay, so that's one level. Let's say that the MDT says we think this child needs to be placed in a residential treatment center or in a Board of Cooperative Education, BOCES, that provides residential treatment. And in our state, we have 3 that provide residential level of care. Then the court order placement statute kicks in. And that court order placement statute says, okay, this child needs a placement. The court is ordering this placement. Therefore, now, DFS, you pay room and board. Department of Education, you pay for educational costs. And then medical care is provided by the Department of Health, mostly because they are in the care and custody of the state, which means they're a foster child. So that's kind of how we get to Medicaid, is because they're in the custody of the state. It doesn't apply in correctional settings. So then that's negotiated through the Department of Education with that specific provider. And then they go through their a cost analysis to determine what is the cost of providing education through that provider. And then the Department of Education, that particular provider, then negotiate the rate that then is paid for by the Department of Education. At the boys' school and the girls' school, all services, non-special ed services, FERPA services, free and appropriate educational services, are paid for by the Department of Family Services in the boys' school and girls' school budgets. And those come through as staff positions primarily. Mental health therapy is provided on an outpatient basis. So educational services in that level of care is provided through the state, through the budget, its general fund, although they do get some Title I funds, small funds, to be able to support some of the educational activities of kids who are there on who have an IEP. So it's a minor amount of money, but there is some. So when you come back to this model, the recalibration, it's a long way of saying we don't get any of those dollars. The children that are in state custody do not get any of those dollars unless they're receiving educational services directly from a school, and that would be in the case of a group home. If a child is placed in a group home, educational services are provided by the local school district.
So if they're on Medicaid, does that get reimbursed then as well?
Mr. Chairman, Representative Zwanitzer, if the provider is enrolled as an outpatient provider with Medicaid and that child receives services through that provider, yes, Medicaid will reimburse. Most typically, though, those kids in group homes are accessing their regular providers, so they would be going to their regular provider, getting those services. Because they're in the care and custody of the state, yes, they'd be getting Medicaid reimbursed, but if they were private pay, they'd also get, that would be the payer of first resort.
And so I was just quickly, Mr. Chairman, when we've talked about this adolescents with high behavioral needs, we've really focused on what we keep saying is the 15 or 20. And when we're focused, I think there's just this population between the K through 12 and the top 15 that, you don't want, they don't just go right from the school system right into being those 15 we can't place. They go in through these any number of ways, and we want them, not to go further into the system. We want them back in K-12. So I guess my overall question is, are we meeting that need right now? Is there we haven't really studied, I guess, in my mind, that population, the not currently in school, but maybe they're still kind of covered by a K-12, even if they're in another program in an institution or a separate facility is what I'm hearing.
Right.
Turn your mic.
Can I ask a question that kind of goes along with that, and then maybe Director Schmidt or Dr. Ballard can answer this. So when these kids, if the school district places the child in a group home, the school district's still getting the ADM for that person, for that student, and they pay the group home the educational costs, if I got that right?
Mr. Chairman, I don't know if that's quite right.
So
School
can I-
district, if a school district places a student, that school district is still responsible. They can find ways to directly provide the services, right? Or working with the other school district that where those kinds of things to provide those services.
But, okay, and fair enough. Point is, but they're still getting, that child is still being shown on their ADM, and they would be getting that money, or no?
I believe so, unless there's an agreement made between the school districts to.
Sure, to shift the residency or whatever we call it. And so then, back to Director Schmidt, when you've got a court-ordered placement, this child has to go to a BOCES or someplace. Does that ADM funding just cease to exist, and you guys then negotiate with BOCES or the PRTF on the education component, and that funding for education comes out of either Department of Health budget, not the school district budget from where the student comes, but somehow out of your budget? How does that work?
So, Mr. Chairman, it depends on the type of placement first, the type of facility. So that's what we look at first. Because, for example, in the PRTF, Medicaid deals directly with that provider to negotiate the educational costs. So the Department of Family Services isn't involved, and the Department of Education, I don't believe, are involved either. Maybe they certify, but they don't pay.
Well,
Mr. Chairman, I don't think so. I think if they're medically necessarily placed, which is when health places them or defines that, the Department of Education also pays for those.
For the education.
The education costs, sorry.
For the education. So I stand corrected, Mr. Chairman, Mr. Co-Chairman.
So, and out of your budget or the ADM for that child to get a free and appropriate education in the public school system?
Mr. Chairman, I have to go back and see, but I thought there was a budget specifically designated to that, but I would have to go back and verify that, the accuracy of that statement.
Mr. Chairman, Mr. Co-Chairman, there was some legislation that happened a few years ago around the ADM, and I don't remember how that landed, but from the general idea that I remember is that districts are provided the opportunity to either forego their ADM if a child's placed in a court-ordered placement, and then the Department of Ed recaptures those costs and pays it, or the school district can pay the ADM to the provider. And Mr. Mayor may know better, but that's how I kind of remember the legislation teasing out.
The seat got cold, but it's okay. Welcome back.
Chairman, Ted Hansen, Outreach Program Director for Region 5 BOCES, former school district special ed director. So a little background in how the special ed works. So obviously, if a student is placed through the IEP process, that goes to the WDE through the 401, and it's fully reimbursed from the state. However, when it's an IEP team placement decision, the contract with the out-of-district placement facility, the 401 covers all of the costs for that placement, and the ADM goes away. So let's say I, as a special ed director and IEP team, place a student in a facility in Wyoming, and that facility says it costs $200,000 to place that student. We set up that contract. That contract is reimbursed through the special education process through the district for the $200,000, and that student's ADM goes away for the school district.
Okay, then what about court-ordered placements?
So court-ordered placements, when that happens, you get a letter from the facility that asks you to do one of three things. One, and Dr. Ballard described this in your choices. I'm going to contract with the school district where the facility exists. I'm going to provide that service myself, or I'm going to forego the ADM completely and let the state handle it. So if you forego the ADM completely, you still have to monitor the student, especially if they're on an IEP as the school district. They're going to return to you. They're going to be your student. But in the process where it's court ordered, then the process reverts to the Department of Ed and Department of Family Services, and the school district forgoes ADM.
In a situation where the school district's foregone the ADM, now it's being placed, it's being taken care of out of the Department of Education. In my mind, I'm seeing that we're taking that ADM money for them to be able to provide those services. I don't know how accurate that is, because I don't know how it comes out of your budget. But then is the negotiated price between WDE and a BOCES or an RTC similar on a daily rate for education that would be reflected in the ADM daily rate if you figured one out?
Right.
Am I making sense with that question?
So the fee, for example, at Region 5 BOCES, that we would charge a school district if it is an IEP team decision, is a higher rate than the reimbursement model from DFS WDE.
I'm talking about, so court-ordered placement for WDE is a lesser rate.
Yes.
The question was, are they reflecting of what the daily rate would be on our ADM model? If you took that 65, 60, whatever it is, that we provide for the student, we divide that by the number of school days, whatever. Does it fit into that?
For education or for the room and board side?
Both.
So.
On the first side, on special ed,
Right, so that's where it becomes difficult, because a student, let's say at Region 5 BOCES, would receive all of the special education and related services as well, speech language therapy, occupational therapy, psychological services. So that daily rate is much higher than the ADM model, right?
Go ahead, Chairman Swanson.
Can you get reimbursed for Medicaid then in that? If they're on an IEP and they're placed there?
For some students, so not currently so unique, right? Wyoming's Medicaid process is different. So with the new process for Medicaid coming into school-based services, that would not come right to Region 5 BOCES, that would come back to the state.
Go ahead, Director Schmidt.
So, thank you, Mr. Chairman. Are you a Medicaid enrolled provider?
Yes.
Yes, okay. So BOCES can enroll in Medicaid and therefore bill for Medicaid services for youth who are Medicaid eligible, regardless of how they got to you, correct?
Chairman, Director, yes, we are. Yeah. It depends on if our providers are, of course, covered. Not all of our providers. We have providers, so some of our therapists are not providers. They're not required to be. So if they are, we request them to get their MPI number so we can bill for those students that are possible. If they're unable to bill, then we go through the mechanism, and I believe we build the WDE for those costs. So if we're not, that's how we do that. But we are eligible as long as our providers who are there. We used to be able to bill a lot more, but when they made those changes, like with everyone else, we were able to bill for became much fewer people.
Chairman Swanson.
I'm not trying to complicate, but do you get kids that were homeschooled that come into the system, have such high behavioral needs, either go through a court order placement, they weren't part of a school district? I sat their education committee yesterday, and a couple of our legislators and other people testifying, no, their kids were homeschooled or in religious schools, et cetera, at a certain age. I don't know if that's common, but what does happen in those situations? And it would come through a court order placement. I'm just making sure we have everybody covered as we're talking about adolescent mental health services.
Director Schmidt.
Mr. Chairman, that's a very good question. The way that I would see maybe a homeschool kid ending up in our system, again, we have a front door that says, are you abused or neglected? Are you a child in need of supervision, or are you a juvenile delinquent? So regardless of where the child was educated, if they met one of those and then came into our system, then went into a placement, then I think the Department of Education would look at home district or their court order placement budget to cover the costs.
Okay, no more complications from you. Okay, further questions, committee, for the two gentlemen who've now got the seats warm again? No further questions. Thank you, gentlemen. Any further public testimony? Anybody online, Katie? Okay, committee, that brings us to the point of the end of our meeting. Directives, Mr. Co-Chair, help me out here. We'll go through. One directive was the bill that we just asked to be drafted. What else have we talked about?
Mr. Chairman?
Anna, go ahead.
Can you please clarify what you want in that bill draft?
We want to do,
Ice cream.
Are we just, are we just funding the counselors?
yeah, we want
K
to.
through 12.
We want to draw that and fund those specific elements, the counselors, et cetera, outside of the funding model right now until the 2025. And we want to make sure that it's added for K-12 under, not just 6-12.
Okay, I think the memo contemplates K through 12, so I can do that. Thank you.
Mr. Chairman,
Yes, go
we were
ahead.
talking earlier, you talked about clarifying what we needed for tier one within the bill draft. So is it just then like the funding the counselors and that piece, or were we contemplating more in that?
I think that as we contemplate that bill draft at our next meeting, then we can add or subtract or whatever it is as we discuss the bill. If we determine that needs to be a higher number, we can talk about that and add it on. Would you not agree, Mr. Co-Chair?
Well, I think that is the question, and I think that we can maybe have a couple of options or three options on what resources that is intended to include. And if you've got suggestions now, give them to Anna, we'll put it in there and kind of flesh that out as she gets that drafted with the committee. But be ready for that a little bit. But
So, Mr. Chairman, I think part of my question I'm asking too is E under number one was sustain WDE's Project Aware. And I was trying to figure out exactly what, trying to figure out exactly what we're looking for, right? Because Project Aware is only supporting literally 13 districts, 13 districts right now. So I'm trying to figure out if that's looking at
well,
trying to.
sustain doesn't mean money, just means that you get to do it.
Okay, that's perfect. That's easy to do when there's no
And,
money.
well, it's serious, and so I don't know what that means, but right now it would mean sustain means that we would like it to continue to move forward throughout the state. And so I don't know, being a little bit ignorant, I don't know that that requires resources to do that, or if there's resources within the current funding model for a district to incorporate that, so.
Mr. Chairman, would it be helpful for us to at least just kind of put a cost estimate together of what we think that would cost to be able to have that discussion?
It would.
Okay.
Okay, Anna? Oh, go ahead, Senator.
Mr. Chairman, if we're going to put a cost estimate, let's extend it to all 48 school districts, please.
Yeah.
Thank you.
Yeah.
Perfect. Anna, what else have we asked you to do? The impossible besides the ice cream?
While she's doing that, just some conversation on our next meeting, because I kind of have some issues both ways, that we need to get some of these bills to standing committees, and most of them meet in September. Our next meeting is until the end of September, and so unless it's going to a PROPS or Management Council, it's probably not going to one of the other, Judiciary or Labor Health. I also heard today, and I don't know how much this committee is going to be involved when those RFPs come in, if the Department of Health is gonna, if we're supposed to be doing something, or we need to wait till they come in on October 10th? Just trying to figure out
If
when
I
the
may,
meeting should be.
that RFP has been extended through those departments, and that it's their baby.
And I think the only bill right
RFI.
now, the only one is just this one we're talking about now that we haven't got assigned. Everything else we've talked with committees. Is that not correct? I think. Labor and Health got the one that we did today.
And we decided, Anna, not to do anything with the vulnerable adult definition.
Mr. Chairman, that's correct.
And on the vulnerable adult council, we're not going to move that forward.
That's correct.
On the civil cause of action,
That one has amendments, and you decided to recommend it to a standing committee?
to do what? I couldn't hear that.
Oh, I'm sorry. So for the civil cause of action bill, you asked for some amendments to that and recommended it, and are going to recommend it to a standing committee.
We are going to.
I did have one question on the civil cause of action. Senator Nethercott had mentioned doing a short memo on the use of personal representatives to the estate of a deceased vulnerable adult. Did you want me to do that memo still, even though we're recommending it to a standing committee?
Yes, please.
Yes, okay. And then for 24 LSO 192, which was the guardianship and conservator letters, that's going to be tabled for now. We're going to talk about it in September.
Correct.
And then for the vulnerable adults being moved into the behavioral health redesign, that's been recommended to a standing committee, probably labor.
To Labor and Health, we've recommended it to that. That's correct.
And then the last one is just the bill draft that we just talked about.
Cool.
Senator Barlow.
Thank you, Mr. Chairman. So where did the civil cause of action end up going? I heard it was being recommended to a standing committee. I didn't know which one.
Judiciary.
Thank you.
And I think it would be my thought that on this last bill, depending on where education, of course, is at if they do another meeting, but it certainly falls well within the realm of appropriations as we consider those appropriations and increase in budget. So I think we could contemplate that going either direction.
Okay, committee, anything further? LSO, anything further? Did you want a flavor on the ice cream?
Nothing further, Mr. Chairman. Thank you.
Peach.
Senator Barlow? Nope. Okay, with that committee, that's the end of this meeting. We'll see.
Do we,
Oh.
so our next meeting then, Katie, is here, September?
28th and 29th?
From our last meeting to this meeting was short, really short. Was a challenge, I know, but please, we got to get the information and stuff into LSO sooner. And so we'll work to improve on that, but well done on a 2 or 3 week turnaround. So good job.
Kudos to Katie. She did awesome. And Anna. Okay, thank you very much, members. We'll see you in September. Drive safe.